Thank you. Welcome, everybody. Good evening to you in South Africa. What we're going to do today, we're going to start, this is a quick overview of what we're going to discuss today, and hopefully address the most common issues that we have to deal with and hear about as the practitioners are working with the Zenlens. We want to do a real quick review, beginning with the selection of the diagnostic lens. Certainly an ounce of prevention is worth a pound of cure, as they say, and by getting off on the right foot, by making sure you have the proper lens shape and the proper lens diameter, goes a long ways towards eliminating the need to do much of the troubleshooting, but issues do arise, and we'll be discussing some of those. One of the most often encountered questions deals with modifications to the landing zone, the advanced peripheral system, as we call it, in the Zenlens. So we'll talk about a few of the ways of evaluating and making adjustments to that. Vision, of course, is a critical component to contact lens fitting, and there are some issues that may be a little bit unique to scleral lenses regarding visual issues that we deal with. We'll talk a little bit about that. Toward the end, we'll talk about customizing the lens shape and just some of the things, the potential abilities that the Zenlens has that we really haven't delved into in the basic training manuals and instructions. But so this is something I think you'll find interesting, and then certainly at the end we want to make sure we open it up to any questions that you might have, any issues that we didn't address. So at this point, I think what I'd like to do is turn it over to Dr. Jason Jedlicka, and he's going to do a quick review on the components of the diagnostic set and the selection, the means to select the proper diagnostic lens to get you started on the right foot. Jason, want to take over here?
Sure. Thanks, John. So it's great to be here with everybody today, and I'm going to review a little bit, as John mentioned, some of the aspects of getting started on the right foot. And I've had the opportunity to work with other fitters who are using the Zenlens within my practices that I've worked in, and I see other people fitting this lens as well. And one of the things I've noticed is that other people don't always follow the rules for fitting. And so sometimes when I get called in to try to help evaluate a fit going quite as expected, surprisingly, half the time we backtrack and realize that the initial selection of diameter or shape really wasn't appropriate for the patient. And if we just back up and make sure that we have made the original selection properly on diameter and shape, we can resolve the issues and get a successful fit. So in the diagnostic set, there's really the 4 series of lenses, and there's the 2 different sizes, and there's the 2 basic shapes. And we'll talk about how we select which row we work with, and then once we narrow it down to which row we're in, we really have an easy job of just working within those 6 lenses. So Johnny, thanks. Again, if you've used the lens set, and I assume everybody has, you know there's the 2 different shapes. There's the prolate series, which works for most cones and corneas that are more elevated centrally than peripherally, which would be most normal corneas as well. And then there's the oblate shape, which works on those reverse geometry corneas, and some of these patients can actually have keratoconus or, you know, pellucid marginal degeneration, but they're instances where that central cornea is actually not the steepest part of the cornea, but rather the steepest area comes peripherally. Those patients are better off with the oblate series, so we'll have some examples of that in just a moment. Just to kind of little schematic showing the difference between the prolate and the oblate series. The 2 different lenses with the same sagittal depth of 4900. In the prolate series, that lens stays more closely aligned to the corneal shape in the mid-periphery, where the oblate lens has an additional clearance in the mid-periphery. And the value there, of course, is not only just in corneas that are flat centrally, but corneas that may have an elevation toward the periphery where you want to create more space near the limbus for vaulting over those peripheral elevated areas. So in determining the lens shape, it's important to think about which way we want to go with this. Do we want to do the prolate design or do we want to do the oblate? And certainly some cases are very straightforward. Again, a patient who's had RK, for example, and now just has poor quality vision, and we want to give them better quality vision. That should be a straightforward case where we know we're using an oblate design. Other cases, again, where we have a centrally located keratoconus, that should be simple. Those are prolate design patients. The difficulty comes into some of these crossovers where patients perhaps had laser vision correction, but now they have ectasia, so they're steep and flat. Or maybe a patient has keratoconus, but now they all had intacts or Ferrara rings placed, and so now that changes the shape again. So there's a couple different ways we can make the decision off of topography or patient history. Using topography, I like to look at the map and see just where the steepest location is. If that steepest location is fairly peripheral, again, sometimes that oblate series is going to be the better option. Looking for hot spots on the elevation maps, kind of the same thing. Any areas outside of the center where you know you're going to need more space to get up and over that elevation, again, we're going to want to use the oblate series. Also looking at asphericity, eccentricity, how high of a rate or low of a rate is that, can be helpful. So even though corneal topography in a lot of cases we talk about it's not that crucial to scleral lens fitting, I think it's actually probably pretty crucial, at least in getting us off the ground with our initial lens selection with the Zenlens and knowing which series we want to fit. John, is there any other comments you wanted to make on that slide in particular? I know that's one that you had put together. If you want to back up to the previous slide. Any other comments you have about this slide?
No, I think you covered it. This was just the slide that we did have in our basic training, and I think it's just it's nice. It shows several of the different ways of making that determination of whether to go with a prolate or an oblate.
Okay, great. So this was just a slide of an example. The image on the left, which has the bright red central area, this is a patient actually just fitted him last week with the Zenlens. And as you can tell, the hot spot or the area of greatest curvature change is relatively near the center of the map. And so this patient did very well in a 17 millimeter prolate design lens. It was a very nice fit, great comfort and vision from the outset. The image on the right is actually a patient who has keratoconus or maybe pellucid marginal degeneration, depending upon at what point you transition from calling that patient keratoconus to pellucid. Needless to say, it's lumped together in a corneal ectasia category. And the image on the right, the map, was a patient actually in our clinic here who was originally fitted with a prolate design, but as you look at the topography, you can see centrally the K readings we're getting there are 35.8 by 47.4 in one meridian, the other meridian 52 by 54. If you go down to the bottom of the map, you see the hot spot there is at 60.9, I think. And so that, again, indicates that the area of greatest curvature is actually out toward the periphery. When we put this patient, switched him from the prolate design into an oblate design, he was much more comfortable and got a lot more wearing time out of the lens because we had more clearance over that inferior cornea where it was somewhat elevated. So I hope that kind of clears up some of those instances of when a steep cornea can actually benefit from an oblate design, even though we consider it more of a steep cornea. We really want to look at the central area of the topography versus the peripheral topography to help us make the decision which series to go with. Any questions specifically on choosing the shape of the lens before I talk about diameter? Is that pretty straightforward?
Yeah, I think the attendees are still muted. I don't see anybody typing in any questions, but feel free to do that. We'll check that. We'll be sure to monitor that as we proceed.
Okay. So then we're going to switch over to talking diameter. And here again, you know, the diameter of the Zenlens is not happenstance. This was chosen for very specific reasons. In order for a scleral lens to work properly, the lens has to land beyond the the limbus. We know that a lens which lands on the limbus or is too closely aligned to the limbus is going to create problems with wearing time and symptoms of dryness or perhaps redness. So we want to avoid that limbal interaction. So when we chose the diameter and therefore the optic zone, the width of the smart curve and the limbal clearance curve, and where we had in mind that lens was to land was very specifically designed to fit certain corneal diameters, so that we have to stick with the rule that if the corneas are 11/7 or smaller, we're wanting to fit the 16 millimeter design. It's going to fit the shape of the eye better. It's going to be less apt to decenter than the bigger lens would on a small eye, and it's just made to fit that eye shape better. Oppositely, for that larger cornea, 11/8 or larger, we have to go to the 17 millimeter lens. We can't try to force the 16 millimeter lens on a larger cornea. It just isn't going to clear the limbus with enough space that that lens is going to be a comfortable, proper fit. So next slide if you want to. Okay, again, if a lens is too small, and let's say maybe we've evaluated a patient and we find that their corneas seem pretty typical, or maybe our topographer gave us a number of 11.78 or something, right in that gray zone of which lens do we choose. And let's say we chose a lens that was a little bit small. We're going to find that those dots that are marked on the lens peripherally are landing on or too close to the limbus. And what's going to happen then is the patient, again, will have some discomfort. They might have some injection at the limbus. They may stain at the limbus. And again, it just doesn't create the most comfortable wearing experience where the patient can.
That's great, Jim. I've got it. Thank you. Bye.
Where the patient is going to be able to wear that lens all day long comfortably. If the lens is too large, again, what happens is we get out into areas with increasing scleral toricity, so that's going to create issues, again, perhaps with comfort, with decentration. If we hit an area where we're getting some lens edge lift, we may start getting debris under the contact lens that affects the vision, creates fogging, and again, the lens will tend to ride lower if we've got too large of a clearance zone with that lens. So again, picking the diameter is important to getting an optimal fit, especially if we're trying to problem solve small issues where we feel like we're pretty close, but we just can't get that patient just where we want them to be. We need to reassess whether we've chosen the right diameter. Again, when we go through a fit, the patient who we talked about earlier, who we just fitted last week, I worked with one of my students here, and we pretty much picked right in the middle of the diagnostic set. It's easy to do that when we pick our lens. Once we've picked the right diameter and shape, we can kind of eye up the eyeball, so to speak. If we've got a particularly steep eye, we can move toward the right side of the row, the column, if you will, to figure out which is the best lens to try. If we have a fairly normal cornea, we can move toward the left. But ultimately, it should just take 2 lenses at most to determine the best fit, because once we put a lens on and we measure the central clearance, if we don't have the amount we want, we can simply calculate in our head how much more or less we want, and then find the lens within the fitting set which gives us that optimal sagittal vault that we're looking for. So again, here's just the basic layout of the lens on an eye. We've got that base curve of the optic zone centrally. You have that smart curve that adjusts for changes in sag that's desired. And then we have our limbal clearance curve, which, as you see, should extend with fluorescein beyond the limbal area. And then that fairly broad landing area, which should provide good comfort, reduce the risk of compression and blanching and rebound redness and those sort of things. So the overall picture is a lens where that final drill dot in the diagnostic set, which indicates the outer aspect of the limbal clearance curve, should be just a ½ millimeter or a little more than that beyond the limbus. Then we know we've got the right diameter. And if the fluorescein pattern within the central 3 rings looks fairly homogeneous, then we know we've got the right series of lenses as well. So once we've got the right series and the right diameter, hopefully then the rest of the fit is just fine-tuning.
Dr. Jodlicka, I'm going to ask a question here. One of the most common issues that doctors ask us about in consultation is when they're looking at evaluating the diagnostic lens or the patient's lens on follow-up. Very often they'll describe this thinning. You can see here where there's a little less fluorescein superiorly, especially in toward the limbal region, compared to what you see inferiorly. And I think that's typically due to that little bit of downward decentration that occurs with, I think, the majority of scleral lenses. Can you comment on your thoughts when you see that and what you might do to evaluate whether or not that's something that needs to be modified or resolved, or when is it acceptable?
Sure. I think that when the lids are in their natural position, it's going to be common to see that thinning of the fluorescein superiorly, just as a factor of the upper lid pushing the lens in an inferior position. I think there's been plenty talked about at meetings, at lectures on scleral lenses, that if you've got 1 or 2 clock hours where that fluorescein is thinned out, you can probably be that can be acceptable. The thing I like to do is pull the lids back out of the way and get the lid tensions off the contact lens and then really reassess that fluorescein again. If I still have decentration, which looks like it's creating a superior thinning of the fluorescein, we want to assess again, do we need to go with a toric APS, because typically a toric APS will give us a better centered lens. At the end of the day, I'm not fully convinced that we have to completely clear the limbus at all times. I think that a lens which at initial fitting shows good limbal clearance, but with settling in time shows that it can actually gently touch the limbus. We just don't want to create pressure on the limbus. So I would look for staining at follow-up, as you had mentioned already too, John. If we take off the lens, if we see staining around the limbus, then that's a concern, of course. But thinning of the fluorescein in a couple clock hours, especially if you can pull the lids up and get that fluorescein to extend into that area, or if the patient looks free of staining and has good comfort with the contact lens, I think we can monitor that and live with it.
Very good, thank you. Yeah, because it is difficult to get that lens to center always with no matter what you do in terms of the landing zone or the sagittal depth. So
one thing I would just add too is to go back to that slide is that if a doctor is evaluating a fit and they're not using a Ratten filter, they may not be seeing that they actually have more fluorescein there than they think they do. It's absolutely crucial, in my opinion, when we are looking for limbal clearance that we use a Ratten filter to help determine whether we have fluorescein, because without a Ratten filter you just don't have enough sensitivity to see that maybe 20 or 30 microns of clearance you might have. It just gets lost without having the Ratten filter to amplify the fluorescein.
Yeah, that's a great point, because I've seen pictures that have been sent where in a head-on shot like this, it looks like you have touch, and then they submit an OCT scan that shows that there actually is clearance. It's just less clearance than what is around it, and so that's that fluorescein thin. Sometimes it looks like touch. So the Ratten filter, very good idea. So what we want to do now is we're going to talk a little bit about probably the most common modification that we deal with when we're doing fittings, which is adjustments to the advanced peripheral system, the landing zone. What we'll do, we'll show a few pictures here. This again was from our initial certification training. Just kind of shows a picture of a pretty well aligned lens on the eye. You can see there's no blanching of the vessels. The vessels are free to, the blood is free to flow beneath the edge of the lens. Reasonably well-centered lens, and no signs of impingement or edge standoff. We can make modifications, however, when necessary, and we'll show you a few of the examples of what it might look like when you want to make a change. But I have a few more questions that I'd like Dr. Jedlicka maybe to weigh in on in terms of the timing of the evaluation. Let's talk about obviously on follow-up, timing is not much of an issue. It's going to be however long the patients have the lenses on the eye, and I think as long as they've been wearing the lens for at least an hour or so, you're probably going to get a pretty good sense of how that lens is landing. But when you're doing a diagnostic fitting, Dr. Jedlicka, is there do you look at the edge shortly after you put the lens on, or do you like to wait until it settles a little bit, or some of each?
Sure. I think that when I put a lens on a patient's eye, I am going to immediately look at the lens just for any gross problems that immediately tell me this lens is absolutely way too shallow or way too deep, and so that I don't waste time letting a lens settle that has absolutely no hope of fitting. But if the initial impression immediately out of the gate is that the lens looks reasonable, then I want to give it some time to sit. Typically, I'm going to wait about 5 or 10 minutes, and I'm going to reassess the fit. I'm going to measure that central vault with the optic section, and then I'm going to look at the periphery. And I'm looking for anything which is obvious starting right away, like I can see, even though maybe I don't have blanching of the vessels yet because it's only been 5 or 10 minutes, I think you can usually tell when a lens is obviously tight or obviously loose, just because you're going to have, that edge lift, or you're going to have the lens look like it's kind of digging in. And even sometimes patients will give you that sense, if the lens is too tight, that they're going to have a little bit of discomfort. One great tip I heard was if a patient has a scleral lens on their eye, if you have them close their eyes and squeeze their lids hard, if the edges are too tight, they're going to give you a feedback that they can feel the edges in certain parts of their eye. So I don't have hours and hours for a lens to settle on a patient's eye before I reassess it. We always build in enough vault that we allow for the settling over time, so that we don't have to worry about a lens touching the cornea at follow-up. But the follow-up is like you say, it's almost more geared towards evaluating the peripheral curves after wearing time. So I don't wait a lot of times. I don't have a lot of time to wait. I usually try to make the full assessment within a matter of 15 or 20 minutes completely, and then spend more time reevaluating more carefully at follow-up based upon how the patient's doing with the lens. And usually when they come back for follow-up, I want the lenses in for several hours before their return visit.
And it sounds like you're evaluating primarily with sort of white light. Is fluorescein of any assistance when you're looking at landing zone evaluations?
Sure. So when we first do the fitting in office, we're putting fluorescein under the contact lens. It's hard to use fluorescein there to help with the peripheral fit, because we've already got so much in the eye. But at return visits, we definitely use fluorescein. When a patient comes back for a week or two follow-up with a lens on their eye for a few hours, let's say, I always like to put fluorescein on the the superior bulbar conjunctiva and watch it interact with the edge. A proper fitted scleral shouldn't have a lot of tear exchange. We shouldn't see fluorescein rushing under the contact. That means the lens is just too flat and the edges are too flat, and it's going to create problems. I'd actually rather see little or no fluorescein exchange just with blinking. But then what I would like to do is use the patient's lower and upper lids to gently nudge some fluorescein under the edge of the contact. And to me, a proper edge is going to allow me to push fluorescein under the contact without a lot of effort. And if I can't get fluorescein underneath the edge very easily, that means that the edge to me is too tight. And again, if the fluorescein gets under the edge with no effort, if it just gets under there with blinking, that usually means to me it's too loose. So I like to be able to push a little fluorescein under the edge using the patient's lids and have it move under the lens easily, but again, it really change.
Very good. Another question that I suspect may be subject to some debate is regarding lens movement. I've had practitioners call me and say the lens doesn't move at all on the blink, and they feel they need to do something about it. And other practitioners call me and say, I could see the lens move on blink, and they'd like to tighten it up. Is there a movement? Is it good? Is it bad? Is there an in-between of some sort on that, or is it a matter of personal preference?
I would just assume not see any movement whatsoever. Okay. To me, movement means the edges are loose in some area, and that's asking for debris accumulation and fogging, or it indicates that the sclera itself is toric and you're getting a rocking back and forth of the lens, and that's not good either. Again, a well-fitted scleral to me exhibits zero movement, but it exhibits peripheral curves that with gentle manipulation with the lid give up or allow fluorescein to pass fairly freely.
So it can move. It can move with manipulation, the push-up test, or I've heard some practitioners even talk about putting their finger on the edge of the lens and trying to spin it a little bit, rotate it to see if it moves freely. They're pretty comfortable with that. Especially if they're not seeing movement with blink, but they can move it manually. That sounds like a pretty good combination.
I think that's the best case scenario. Yeah.
Good. And OCT, of course, we're going to show you a couple of OCT images here that I think will show you the value of that if you wanted to take the time and if you have that as an option. It's also going to demonstrate why we often see this compression ring when you take a lens off of the eye, and we'll talk a little bit about, as we go through these, some of the adjustments, how big of an adjustment you might want to make. So this is a photo of an OCT that I think shows a very nice alignment, and Dr. Jedlicka, you can jump in if you disagree with something I say here. But this lens it shows the landing zone, the area of contact here at 1.48, 1.5 millimeters, which is just about the width of the landing zone. So it's really laying just about the way we want it to be. You can see it does compress into the conjunctival tissue, and we know that's the norm, because that's why that lens we have to give that lens time to settle. And you can see, I think a good way to evaluate it is if the very apex of the edge right here, the center of the lens, is approximately even with the conjunctival surface right outside it. That's about the proper alignment that we like to see. And again, if you can think of this lens as diagnostic lens, is about 350 microns thick. You know, it tapers down here before we get to the edge radius. It's probably about 250 microns. And you can see if you draw a line, say, extend this conjunctival plane here, it would run pretty much right through the center of the lens, which is a good thing. And you can see that that's going to sink about 100, 150 microns into the cornea. And this is why when you take a lens off, even a well-fitted lens, immediately after removal, you'll often be able to see this impression where the edge of the lens was. It's typically not something to be concerned about. perhaps I don't know if timing is even an issue, but I think usually this conjunctival tissue will bounce back, and that becomes much less obvious after maybe 15 or 20 minutes. I don't know, Dr. Jedlicka, do you have any? Is there any guideline when you're looking at that impression ring that's left, or is that something you pretty much ignore after lens removal?
I think that if you have a lens where the peripheral system is too steep, you're going to get the bulk of the settling right at the edge, deeper and more well-defined impression ring. I'd rather not have an obvious, well-defined impression ring. I'd rather that impression ring be more difficult to see, meaning that it's got a more gradual slope to it, that the very, very edge of the bearing isn't digging right into the conjunctiva.
Okay, good. Well, and this next slide here is one that I think does show perhaps an edge that's a little bit steeper relationship to the scleral plane. You can see as it sinks in, the edge of the conjunctiva is much closer. It's well above the apex of the edge of the lens here. So it's almost even with the front surface of the lens. You can even see that tissue kind of begin to creep over the front edge of the lens just a little bit. It may be even a little bit more so in some of these other adjacent images here. So this would be a case where I think you would want to lift the edge of the lens. And again, if we're thinking in terms of an edge, just for example, and you're not going to have necessarily an OCT image, but if you see that this edge is burrowing down into the conjunctival tissue, you can see that if we lift this up 30 microns or 60 microns, it's certainly not going to create a situation where that edge is going to lift. It's a question that comes up as well, how much more do I need to flatten this landing? Each step in our APS Zenlens adjustments is 30 microns of edge lift. In other words, it's going to move this edge up 30 microns one step. I would say right here, the apex of the edge is probably a good 60, maybe even 100 microns below this conjunctival plane here. So I would think you would want to flatten this lens, or at least this aspect of the lens, by 2 or 3 steps of the APS adjustment. If the impingement is obvious, if you see blanching of the vessels during the diagnostic fitting, if the blanching is occurring within 20, 30 minutes, that tells you you're going to have to do more than just a single one-step adjustment. Typically 2 or 3 steps would be appropriate. If you're looking at a lens, sometimes the practitioners will say, it looked okay, it might have been a little steep, a little tight, or a little flat. That's the scenario where I think you're safe if you just make a one-step adjustment, 30 microns, maybe ease your mind a little from what you were seeing. And it's 30 micron adjustment is certainly safe. I think patients aren't likely going to make a noticeable difference in how the lens feels. And of course, lens patient comfort is another means of evaluating. Here's an example of one that's a little more obvious. This would be the type of thing you can see with white light. This is actually a bubble, a series of bubbles. If we had it in video, you'd actually see these bubbles moving underneath the edge of the lens and into the corneal chamber, where they would coalesce into creating a larger air bubble. So this was a rather obvious example where the edge is lifting off too far from the scleral, the conjunctival surface, and it's allowing air to get through. So you would need to steepen this. I think, again, if you're seeing air bubbles, you're going to need to make an adjustment of probably a good 3 or 4 steps of steepening, especially if you're going into a toric type of design. Sometimes you won't see the air bubble, but this might be an example that Dr. Jedlicka mentioned, where you may just simply see some fluorescein passing through here, or settling in underneath the landing zone. And again, especially if you saw it in one meridian, but not in another meridian, that would be a good indication as to when you may need to go into a toric lens design. So this is an example of an eye that I think this was one of Dr. Jedlicka's patients, where you can see a little bit of impingement and some blanching of the vessels. Some of the vessels are allowing the blood to pass through, but you can see it's being cut off a little bit on this side. It's a little bit whiter over here. Inferiorly, it looks pretty good. So maybe even a little bit loose. It might be this might be a situation where if you had brush some fluorescein on the outside of the eye on follow-up, you might actually be able to see it flowing through here without any nudging of the lens. So this might be a case where you'd have to do a little bit of toricity, maybe steepen this meridian 1 or 2 steps. Depending on what you saw with fluorescein, and maybe flatten this meridian. Probably not a whole lot. It's not severe blanching, but maybe 1 or 2 steps flatter in this meridian.
John,
yes.
Can you go back to the left side? Can you take your cursor and put it at the inferior view there? And the vessel on the left side, the real bold vessel that comes through, can you see how that vessel, there's just a little bit of deflection of that vessel as it hits the edge of the lens? You see it shift? That's a good indication that that edge is a little bit loose. It's probably lifting away from the eye just slightly, and that's causing that deflection in the course of the vessel. It's an optical thing. It's not a true movement of the vessel, but that lens lifting off, the optics of the lens cause a shift in the visual of that vessel, and that's another way to look and see if a lens is a little bit loose.
Oh, that's a great tip. So it's just sort of like a diffraction, like when you stick a pencil in a glass of water, the image gets moved sideways. Oh, that's very interesting.
Right.
And this is just to show you again what we're talking about when we make these adjustments in the landing zone. And each step is a 30 micron adjustment in the axial edge lift, so you're just moving that edge down. If you make the APS steeper, you're moving the edge up a little bit. If you're making it flatter, I've got a graphic that they'll show you, I think, in motion a little bit better idea what we're talking about. This is another example of a lens that I thought required a toric lens design. Here you'll see horizontally it doesn't look too bad. This side here at 3 o'clock actually looks pretty good. Now I'm looking to see if that vessel's moved sideways. I'm not seeing it. It doesn't look like it's too loose. Over here at the 9 o'clock position, a little bit of blanching, a little bit of injection in the limbal area. So I think we might want to, this might be one of those situations where you say, maybe I should flatten it. So let's flatten that by 1 step. But what's interesting here is you look at the vertical meridian, and now it's a little more obvious that you're seeing blanching of the vessels where that blood flow is getting cut off here superiorly and inferiorly. So this is an example of what would be against the rule scleral toricity. Not as common, but certainly not rare. So this is an example where we would order a lens with, let's say we decided to go flat 1 in this horizontal meridian, but we wanted to flatten it maybe 3 or 4 steps in this vertical meridian. So what we might do in this case is order the APS, the landing zone, with a flat 4 and a flat 1. And now this is important. What happens is we're going to put on the Zenlens, that's going to have a little drill mark on the flat meridian. Wherever the flat 4 is, when it's manufactured, the lathe is going to, on the front surface of that flat meridian, put a drill dot at that flat to mark the flat meridian, 1 on each side of the lens, pretty much about 1.5 millimeters in from the edge of the lens. You want to look to see where those dots align. They will rotate in its most natural position. Now we think, well, we think the flat meridian's going to go here. This is where we want it to be flatter. So we would expect to see that drill dot somewhere, right in this vicinity here, and another one up here. But it may be that the flat axis of the sclera isn't precisely axis 90. It might be over here at axis 110 or 120, something like that. It's important that you make a note in your chart where that flat axis is aligning, and I'll tell you why it's important for several reasons. Number one, if you're going to make another adjustment after the patient comes in and you decide, oh, I think I need to go a little flatter in the vertical meridian or the horizontal meridian or obliquely at axis 140 or something like that, you need to know where the flat axis is aligned so that we know which meridian you need to actually make the adjustment to. And also, perhaps even more important, is if the eventuality comes up that you need to put front toric optics on this lens. One of the ways we stabilize a lens is if you have a toric peripheral system, we need to know where that flat axis is aligned as precisely as possible on the eye, so that once we know that, then it allows the lathe to cut in the cylinder on the front of the lens and put it at the axis where you want it, where you tell us you want it at axis 115. The only way we can get it there is if we know how the lens is going to align on the eye relative to that flat axis. So we've kind of talked about I think covered most of our bases on the landing zone. I'm just going to look and see. I don't see that anyone else has typed in any questions yet. So we'll talk. I just want to talk real briefly about this other feature that we have offered now for the Zenlens called the Micro Vault. And what this is essentially is in lieu of putting a notch in the end of the lens, we feel this is a much more precise way of dealing with some of those peripheral anomalies that you might see, like a pinguecula, most the common one that we deal with. And it's simply a controlled ripple that we manufacture in the edge of the lens to bring that edge up and vault. Let me change that word. We're not actually trying to vault over the pinguecula. We're simply trying to raise that edge up to lessen the compression of the edge of the lens that it might otherwise be pushing into a pinguecula or elevated part of the sclera out there. So this is what it looks like on from the top view. It's just rises up above the normal edge alignment. From the underside, you can see it just looks like a dimple right at the edge of the lens. And it's something that, again, it can be fairly simply ordered. It has several parts. Obviously, we need to know where we want to put it. Is it on the nasal side? Is it on the temporal side on a right eye? Or if it's on the left side, the nasal side is 180. If it's temporal on the left eye, we need to put it at axis 0. And that's usually where they end up, at axis 0 or 180. Axis maybe 15 or 20. So that tells us where to put it. We're going to need to know the width of the lens, typically, or the diameter of the micro vault that we want, and usually about 3 millimeters is kind of 2 to 3 millimeters is a pretty good size. We don't want, again, we're not trying to vault completely over the pinguecula because that would create a channel for air to work through and get into the chamber. And then the height or depth of the micro vault, then typically we're usually looking at something in the range of 200 to 300 microns of elevation, where this would simply rise of the micro vault of this little arch, if you want to think of it that way. It would be about 200 microns or so, whatever you want to specify. If it's a large pinguecula, to 300 or so. So anyways, it's a nice option. Wanted to make you aware of it. If it's something you're interested in, you're going to need to contact consultation, and we can talk about how we would order that and specify that on order entry for the manufacturing. So now I think we want to talk a little planes. One of the most common things, of course, is if you're not getting good vision, if there's lens flexure, you may get cylinder in the over-refraction. So you want to check for cylinder, obviously assuming you've already optimized based on spherical correction only. If that's not doing the job, you put in some cylinder, and if that seems to take care of it, then you want to check for lens flexure. You can do Ks or topography over the top and of the lens, and then if you do see flexure, then typically you're going to want to order with flex controlness. That's the easiest thing. Sometimes check again if you're seeing flexure, check for that landing zone, and maybe a toric peripheral curve might be more in order. If there's a lot of toricity on the sclera, that could lead to lens flexure, and putting a toric peripheral curve on there along with maybe some extra thickness and flex control will very often take care of the flexure that way. If there's not flexure, and I think this would be an example of a situation if there's no lens flexure, you do topography here and you can see there's no obvious bow tie or signs of cylinder running through here. This would be a case, it's probably lenticular cylinder, and we would do a front toric design which is simply stabilized by the dual thin zone dual elliptical stabilization system, and that's been working quite well. It just basically becomes essentially the same as fitting a toric lens in that case. So, and I may ask Dr. Judlicka to jump in here on some of this too. What if over-refraction does not improve the vision? Sometimes we alluded to if there's debris uptake that gets drawn into the tear film, possibly because the landing zone is a little too flat or maybe requires some toricity, or if there's excessive vaulting central clearance over the visual axis over the pupil area, I think sometimes that can obscure vision a little bit, even if in the absence of lens flexure. So these are some of the things, and I don't know if Dr. Judlicka, is there anything, any tips that you have if you have a situation sometimes where doctors will say, the patient's just not getting as good a vision as I had anticipated, and I'm not getting any lens flexure. What else is there maybe that you might consider?
Well, I think that was a great point about the vault. I had an interesting case just within the last couple weeks where we fitted somebody in lenses and they had a very similar corneal shape in both eyes. So we put a lens on one eye that had microns of vault. We put the next closest lens on the other eye, which had 500 microns of vault then. And they noticed the vision out of the eye with the less vault was noticeably clearer. So when we finished our over-refraction, we pulled the shallower lens off and put it on the eye that had initially had the deeper lens. And then we over-refracted that lens. They were seeing clearer again. So I do think that bringing vault down, not over-vaulting, can sometimes help the vision by keeping that vault closer to, 250 to 300 as opposed to 450 or 500. I think that definitely can help. Some of these patients just have difficult eyes, and we're fitting them in a sclera because they have severe keratoconus or they've had injury to the eye, and sometimes it's just not going to get better. I think we want to make sure that we don't miss anything else with the rest of the eye, like a cataract or the health of the inside of the eye. But I think once you've ruled out flexure and you've decided, whether you have a proper fit, and again, sometimes having those toric peripheral curves to better align the lens will sometimes give better visual acuity too if it's better centered. But sometimes it's just a challenge, and you do all the things that we've already mentioned, and you just do the best you can.
Very good, thank you. And the last point here is sometimes doctors will say, well, I've got a lot of minus power in this lens, or I've got more plus power than I'd really like. Is there a way we can, do anything to change the base curve to modify the lens power? And that is an option with the Zenlens. It can be something that can be achieved relatively easily. And I'm just going to talk about this and what happens when you change the base curve. And remember, the way this lens is designed, the smart curve technology disengages the base curve change from the sagittal depth change. So you can, in other words, you can change the sag without changing the base curve. You can change the base curve without changing the sag. And so that's what we're going to talk about right now, is what happens if you have a central clearance that you like, determine the sag value that you want, let's say in this example 4,800 microns, but you want to modify the lens shape a little bit, maybe not as dramatically as going from an oblate to a prolate. If you remember that earlier slide, we showed this very similar type of relationship where a prolate lens versus an oblate lens, there was about 350 to 400 microns of extra peripheral clearance in the oblate design, but maybe you don't want quite that much. Or in the case of, let's talk about changing the, I want to change the lens power. If you have a base curve of whatever, 45 diopter, a 750 base curve, let's say, and you wanted to decrease the minus power, you could flatten that base curve. Actually, in this example, what we have here is a 710 base curve. If you wanted to flatten that base curve by 2 or 3 diopters to a 760 base curve, you could reduce that minus power by 3 diopters, but you need to be aware it does change the shape of the lens. In this case, the 710 base curve is represented by the black line here, and if you flattened it to, I think this is 3 diopters to a 760, you'd be creating that. It's a relatively minor change, and it's not going to affect the fit of the lens much in most cases with that. So that's something where you can change the base curve a little bit, up to maybe 2, 3, 4 diopters maybe, without making a really significant change in the fit of the lens or the lens shape, and that can modify your lens power. I don't know that that comes into much significance in terms of optimizing vision, but I know a lot of doctors are more comfortable with reduced power in any sort of lens. A kind of a rule of thumb to think about here is if you steepen or flatten this base curve to increase or decrease this clearance, each diopter that you change the base curve is going to move this point out here at the edge of the optic zone up or down about 40 microns. If you flatten the base curve, it's going to move up. I'm going to show you how this works on a schematic here in a second. So here's an example of a lens where we want to maybe change the shape to improve the fit. We have a lens here where you have central clearance of about 150 microns, which might be okay if this was the end of the day, but it's getting a little close to the corneal surface for comfort. And certainly if this was a diagnostic lens and you were anticipating any more lens settling, you'd want to get a little more clearance here. But if you look out in the periphery, you can see we've got quite a bit of extra clearance, more than what we need here. So this might be a case. Well, first off, if this were an oblate-shaped lens, what we could do is move this into a prolate, a steeper base curve, and that would bring this down quite a bit. Remember, there's about 400 microns difference between that. That might be a little more of a change than what you're looking for. So here's what we can do. I'm going to just real briefly bring this piece of software up here and show you. This is a sort of a schematic. This is hand-drawn. It's not perfectly to scale, and some of these curved junctions are exaggerated to make a point. But think in terms of this being the base curve of the lens. This tan curve out here would be the smart curve. So point B is the junction where the edge of the optic zone meets the smart curve. In here we have the limbal clearance curve, and then out here is the landing zone. So the lens is going to land right here at about point D, where the landing zone begins, and pretty much align, hopefully, out here on the sclera. And then this area, these 3 curves, the limbal clearance curve provides this vaulting over the corneal surface and contributes this much sagittal depth to the lens. The smart curve then connects the limbal clearance curve to the base curve. So let's say we were talking about wanting to increase the central clearance on that example we just saw. Well, what you would do is it's pretty simple. You simply specify, I want 100 more microns. We had 150 microns of clearance. What would happen is we would simply readjust this to increase that 100 microns. The smart curve makes that calculation. How much steeper do I have to go to produce that 100 microns? And you've now created a situation, you've just lifted that entire optic zone 100 microns. Now we have the central clearance that we want. But if we go back to that previous example, we had more clearance than we needed out at the edge of the optic zone. So what you could do is, this is an example where you could steepen the base curve. And let's say we wanted to bring this down. We raised it up 100 microns. Let's say we wanted to bring it down even more than that to get rid of some of that excess clearance. Let's bring that down 200 microns. You could do that by steepening the base curve by about 4 4.5 diopters maybe. The precise amount will vary depending on whether you're in a 16 millimeter lens or 17 millimeter lens. But again, that rule of thumb, every diopter is about 40. Then what would happen is the smart curve would simply recalculate itself and say, okay, now we steepen the base curve, so we're creating more sagittal depth through the optic zone. Means we don't need to have quite as much sagittal depth here, so it calculates what it needs to do to connect that point. And then just an example too, we talked about those APS adjustments when you modify this. That's simply you're moving this point up or down 30, 60 microns, 30 microns with each step. So you can see that's just simply moving this point up or down. And it really doesn't impact anything else that's happening with any of these other curves. I'll show you another example here with a limbal clearance curve. Let me get back to this is another case. Let's talk about. This is a patient that actually was just done this last week. It's a relatively large corneal diameter. So the doctor picked out a 17 millimeter lens and from the diagnostic set. Central scarring. There's some elevation there. Went with the prolate design, and you can see had pretty good clearance centrally here, actually, with the optic section. When you look at this, I don't know how clearly you can see this, but there's actually probably a little more clearance than what we need. It's about 500 microns of central clearance here. The doctor was concerned about this shaded area here. I thought, and I actually thought it was just a shadow from the upper lid, but he told me this was actually very close to touch. Let me bring this up here. So very close to touching here. You can see it a little bit better. You can see that excess clearance there. So the doctor said, well, I want to bring this down a little bit to the central clearance. Let's bring that down. This hasn't settled fully. He thought maybe reducing that by 100 microns would allow for enough extra settling. But he was concerned that if he did that, he was going to get this touch not just at the limbus, but even in from the limbus a little bit. So what we decided to do was to flatten the base curve. And let me go back to my PowerPoint here. And this was a case where we wanted to bring this sag down. So we had moved this up previously. So let's bring this down 100 microns to get rid of that excess clearance centrally. But he wanted to increase the clearance out here in the periphery. So now we would need to flatten the base curve. Well, if we flattened it at 2 or 2.5 diopters, that would just bring it back up to where it was before. So we actually flattened this base curve by about 4 diopters to create 100 microns additional clearance from what they were looking at. And then simply, smart curve would simply have to readjust itself. So what you've done here now is we've brought point A, center of the lens, down 100 microns. We've elevated point B up 100 microns from where it was before. And we were concerned a little bit about the clearance, not just at that point, but actually all the way out to the limbus. So what we decided to do there was let's increase the limbal clearance by 100 microns. And so we did that as well. And then that brought this point smart curve just does its recalculation. So what we've done, essentially, we brought the center of the lens down 100 microns. We elevated point B and point C. Each went up 100 microns. So we've increased the clearance through this entire area. We've essentially moved all 3 of these points. And if we needed to, we could do something with the landing zone and do that without influencing what else goes on here. So it's just a way of showing the potential of what the Zenlens can do. So in this case, what we did, we ordered the lens with about 4 diopters flatter. His over-refraction was a -2 over the -4 lens, so over the -2 diagnostic lens, which would have yielded a -4 total. Since we flattened the base curve 4 diopters, it actually brought the lens power down to plano. The original central sag was 5200, so we ordered it with 5100 to bring that down. flattening the base curve, of course, put the peripheral curve back up, and we added that 100 microns to the limbal clearance. So a lot of moving parts. I love the fact that we can do these types of things with the Zenlens. It has that potential. But I'm going to go back to the very initial comments that Dr. Jedlicka made. A lot of times you don't encounter those problems if you start with the right lens. The Zenlens diagnostic set and the lens design itself were created to allow the practitioner to keep it simple. The Zen masters often use these parables and Zen cones, as they call them, to their students to ponder. And I think one of the lessons they're trying to teach them is that thinking doesn't necessarily equate to understanding, and that sometimes thinking too much can become more of a hindrance. So you do want to keep it simple. Let the Zenlens design do its work. Get the right lens to start with, and simply, make the simple adjustments first. Don't overcomplicate things. That last example I showed you was a fairly technical, advanced level of customization of the Zenlens, and the type of thing that keeps me employed. So you use consultation when you have that ability. You can email us, those of you that are overseas, and or call us if that's a convenient option. So that's pretty much the fitting points. This is just a troubleshooting guide. I think we touched on most of these. You might take a quick look at that and see if that triggers any questions in your mind. And maybe Tom can unmute everybody and see if anybody has any questions, or if they need any. We'll be happy to answer any questions you might have, or re-explain something if I manage to confuse you at all. Or was there any issue that when you signed up for this that you were hoping we would cover and maybe we failed to address? Now's the time to ask. Dr. Jedlicka, do you have anything to add to any of my comments, or did you think of anything else that?
No, I think that was pretty much exactly what I would say.
Okay, very good. Well, I think we just about filled an hour, maybe even a couple minutes more than that. I think that's what we were shooting for. So I guess I'll thank you. I'm not hearing any questions from the audience, so thank you all very much. Please be in contact with us as you work with the lens. We love to hear your feedback, and we learn from what you tell us and the questions that you ask us, and some of your thoughts as well. So we look forward to working closely with all of you as you continue to work with the Zenlens on your patients.
Thanks, John. Thanks, Dr. Jedlicka. Kim, was there anything you wanted to add before we close out?
No, I would just like to say thank you very much, Tom and John Davis and Dr. Jedlicka, for doing that for us. We really appreciate it. I found it very informative, and I'm sure everyone would have benefited from today.
Very good.
Very good.
Happy to do it.
Thank you very much. Thanks, everybody. Good evening.
Thank you so much.